Hello, and welcome to ID Talk, answers from infectious disease experts. I'm Dr. Scott Olson, a pediatric infectious diseases specialist at Banner University Medical Center in Tucson and associate professor of pediatrics at the University of Arizona College of Medicine. Along with Dr. Nathan Price, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. And if you're looking at the thumbnail of the podcast, Dr. Price is the stately young man on the right, and I'm the one on the left. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thank you for tuning in today. This is the week of August 4th, 2025. Let's go ahead and jump into the questions. The first question this week comes from a member who asks, what are your thoughts on national AAP having a different vaccine schedule from the CDC? I'm going to try to keep my answer brief, otherwise all of you are going to be stuck listening to me rant for the next several hours. In general, like a lot of us, I feel distressed, frustrated, horrified, and indignant that at this current moment, we can't really trust a lot of the messaging coming out of HHS and CDC when it comes to vaccines. If you remember the ACIP meeting from just several weeks ago, there was lots of vaccine denialism and bad science that was discussed. If we look at decisions that are being made from the head of HHS, we know that there have been decisions about COVID vaccination and influenza vaccination that go against scientific evidence. So if we're in a position right now where federal leadership at HHS and CDC are willing to ignore medical science with regards to vaccines, then other groups are going to need to step up and take the reins to lead on vaccine messaging. And because I'm a pediatrician who grew up in the 80s, this current moment reminds me a lot of a fairly famous quote from Fred Rogers, who said, "When I was a boy and I would see scary things in the news, my mother would say to me, 'Look for the helpers. You will always find people who are helping.'" And so despite all of the craziness going on in the medical world over the last several months, I do feel oddly inspired because looking around, I think we can see a lot of helpers in our community. So, for example, in addition to the AAP, ACOG, IDSA, and the American Academy of Family Physicians have all stated that they will be putting out their own vaccine guidance. And other really interesting initiatives are going on, such as the Vaccine Integrity Program, which is being spearheaded at CIDRAP at the University of Minnesota. So while it is frustrating that we find ourselves in the current moment, it's also encouraging to see the number of experts in our field stepping up to make sure that evidence-based scientific guidance is available when it comes to vaccines for our patients and their families. Some other great resources for evidence-based recommendations with regards to vaccines include obviously the AAP Red Book, but also Immunization Action Coalition and the Vaccine Education Center through CHOP, if you weren't aware of those resources already. And I just want to finish my message to this question by stating that there are still lots of phenomenal scientists and clinicians working at the CDC, the NIH, the FDA, and lots of other groups under the HHS umbrella. And so I don't want to come across as maligning or impugning the work that they're doing. Really, I think what we're seeing is a crisis in messaging coming from leadership in those groups based more off of political motivation, not scientific evidence. And I think that's enough on that topic for today, so let's move on to the next question. And our second question this week comes from a member who asks, in Arizona, if a patient tests positive for gonorrhea or chlamydia, does the lab automatically report this to the state, or does the healthcare provider need to report it to the state? And the easy answer here is yes. Actually, both the lab and the provider are required to report infections to the state. And to get a little more granular, there's actually two separate Arizona administrative codes mandating reporting from both healthcare providers, which is R9-6-202, versus those that require lab reporting, which is R9-6-204. And I do think this actually serves a purpose because obviously, once the lab result is finalized that makes the diagnosis of one of these reportable diseases, it's important that that information be transmitted to public health groups as soon as possible. But I also think that clinician reporting can offer a lot of valuable clinical information to public health groups if needed. And clinicians can make reports either by contacting their county's Department of Health or by submitting it electronically through Arizona's Medical Electronic Disease Surveillance Intelligence System, or MedSys. Now, to go back to the original question and throw a little bit of a wrench in the works, it is important to know which diseases are actually reportable within your state. So, for example, the member asked about gonorrhea and chlamydia. But if we actually look at the list of reportable diseases, they are different whether you are a lab or a clinician calling in. So, for example, labs are still required to report any positive chlamydia testing. However, that's not technically one of the reportable diseases for clinicians in Arizona, compared to gonorrhea, which is reportable by both labs and clinicians. So it's a little confusing. So I would take some time going to the Arizona Department of Health Services website and look at the actual list of reportable communicable diseases for clinicians. And moving on to question 3, a member wrote in asking, now that measles cases are at the highest they've been since 2000 in the United States, is there any new guidance or news around patient care and diagnosis for measles? Now, this is a wonderfully timed question because if you go back to our last episode of ID Talk, Dr. Price and I had a sit-down conversation with 2 of our residents here at the University of Arizona, Dr. Anne-Marie Saravana and Dr. Emily No, about pertinent clinical questions related to measles in the current environment. And so I'm not going to go back and rehash everything we discussed during the prior podcast, especially because Dr. Price probably said it more eloquently than I can, but I'll try to hit some of the high points. When it comes to diagnosing measles, I think the first thing to say is that because of the ongoing outbreaks in the United States, we all have to have just a lower threshold of suspicion. That being said, patients should have some epidemiologic risk factors, such as travel to an area where there is an ongoing outbreak or obviously exposure to a known case, before we should be going down the pathway of really strongly considering measles in one of our patients. If you have a patient who has epidemiologic risk factors and then presents with a clinical case that is consistent, so for example, cough, conjunctivitis, and coryza leading into high spiking fevers and a head-to-toe rash, then measles testing should be pursued. In that setting, the best course of action is to reach out to your local county Department of Health, who will help coordinate appropriate diagnostic testing, which is usually done by PCR testing off of a nasopharyngeal, oropharyngeal, or urine sample. And then when it comes to therapeutics, we still don't have any targeted antiviral medications that work against the measles virus, so most of our care is supportive. Now, there's been a lot of conversation in the lay media about vitamin A and measles, and so I think it's important just to quickly talk about that topic. Now, we know that in disaster situations or in developing countries where there's a higher rate of nutritional deficiencies, administration of vitamin A to pediatric patients with measles can mitigate some of the more severe manifestations, such as severe ocular disease leading to blindness. Now, what's important to point out is that vitamin A does not prevent acquisition of measles, and it also has not really been looked at to show benefit in developed countries such as the United States, where the underlying rates of vitamin A deficiency are much lower. And I think this is important to point out to families, especially those who may be vaccine hesitant, because we have been seeing individuals who are being hospitalized for vitamin A toxicity because they're being administered supratherapeutic doses in hopes that it would prevent measles acquisition, which unfortunately just does not work. So what does work for prevention? Well, the MMR vaccine works wonderfully. And one of the things that's important to remember is that that second dose of vaccine does not need to be held until the 4-year-old well child visit and can be administered 28 days after the first dose. So if we start seeing increasing activity here in the state, there may come a time where the recommendation is that the MMR vaccine should be administered at 12 months and then as soon as possible thereafter, so that we don't have patients who are potentially at risk for 3 years in a setting where there is increased measles activity in the U.S. despite all the focus on measles, we're not there yet. So currently the recommendation is still that routine immunization should be administered at 12 months and then at 4 years before school entry. But over the next several months, we'll see if those recommendations happen to change. Okay, moving on to the fourth question. A member asks, with regards to vaccinating against vaccine-preventable diseases, some of my fully vaccinated patients have asked if they may obtain vaccine titers to confirm they created an appropriate antibody response to MMR, varicella, hepatitis B, and hepatitis A, and see if they need a repeat series. If a patient is fully vaccinated, but if one of those comes back as not immune, does that indicate that the patient may be at increased risk of disease if exposed, and should the patient receive a full series of that vaccine a second time? In general, routine post-vaccination antibody titer testing is not recommended for healthy individuals who have completed all of their recommended vaccines, mainly because serologic assays might not reliably reflect the patient's true immunity, which can lead to things like unnecessary revaccination. Now, this is in part true because we know that commercial tests are not testing for the same neutralizing antibodies that we know are the correlates of protection for most infections we immunize against. Additionally, testing for antibodies only looks at one arm of the immunity that's generated after vaccines. So, for example, testing antibodies will tell you whether or not the patient had a successful humoral or B-cell response, but that doesn't tell you anything about the patient's cellular or T-cell immune response. Antibody titers can also wane over time, even in fully vaccinated immunocompetent individuals, but it doesn't necessarily indicate that there's been a loss of protection because breakthrough infections remain rare in those populations. So for all these reasons, routine titer checks after immunization is not recommended for most individuals. Now, that being said, there are some exceptions for certain high-risk groups, such as immunocompromised patients, healthcare workers, patients on hemodialysis, and others whose clinical management depends on knowledge of their immune status. But this is, again, only for specific patient groups and shouldn't be applied uniformly for all of our patients. And moving on, the last topic for this week is any additional topics or facts that you think podcast listeners would like to know. So this is fun. We are going to get to do a little bit of ID potpourri to close out this episode. First up, it sure seems like avian influenza has disappeared from the news cycle, so I thought I'd go and just do a quick review to see how things are going on that front. Now, there is still H5N1 circulating in the U.S., and in large part, it's mostly contained to bird populations, including commercial flocks here in Arizona. Now, thankfully, there has not been tons of additional human cases over the last several months, and currently there have been 70 human cases identified in the United States with one death since this was first started to be tracked about a year ago. Now, what I wanted to point out here was that there was a New England study, I believe late 2024, which is worth going through. Now, this study looked at disease among farm workers in California. And what was really encouraging was that disease tended to be mild among human cases, with about 50% experiencing fevers and 50% experiencing conjunctivitis, and there was no identified person-to-person transmission. So while it's still important to be following avian influenza because of the ongoing circulation among animals in the U.S., human disease still tends to be rare, it tends to be mild, and there has not yet been person-to-person transmission. And I'm sure we here at ID Talk are going to keep following avian influenza, so we'll keep you updated if there are any big changes. Next up, there have been some pretty significant changes with regards to which medications are available for HIV pre-exposure prophylaxis, or PrEP. Most pediatricians are probably familiar with the use of combination tenofovir and emtricitabine, or Truvada, as an oral option for HIV PrEP. But there are also injectable options, and just this year, the FDA approved a novel antiretroviral called lenacapavir, which is an injectable capsid inhibitor, which can actually be administered every 6 months and provide adequate pre-exposure prophylaxis. The FDA approval was based off of 2 large studies that demonstrated the effectiveness of this injectable HIV PrEP option. The first study, called Purpose 1, looking at HIV-negative cisgender women, and Purpose 2, looking at HIV-negative individuals who have sex with men, not including cis women. And when we look at the efficacy of lenacapavir, in the Purpose 2 study, they actually showed a 96% reduction in HIV incidence, and it was 89% more effective than oral Truvada at PrEP. And interestingly, among 2,180 participants in that study who were on lenacapavir, there were only 2 new identified HIV cases. So this is a really exciting opportunity for HIV PrEP for adolescents or high-risk patients. There have been some big changes in recommendations for treatment of tuberculosis in the last year. The ATS published updated tuberculosis treatment guidelines that now recommend for those patients over 12 years old who have a drug-susceptible isolate, they can be treated with 4 months of rifampicin, moxifloxacin, INH, and plus-minus ethambutol. Now, this is based on our knowledge that fluoroquinolones actually work very well against treatment of tuberculosis. However, it has never been part of a standard recommended regimen. For younger individuals aged 3 months through 16 years old, the ATS guidelines now also say that for non-severe drug-susceptible isolates, those patients can be effectively treated with a shorter 4-month course of INH, rifampin, pyrazinamide, plus-minus ethambutol. And finally, especially because the pipeline for novel antimicrobials is relatively anemic, I always get excited when I hear about a brand new agent that is being studied or available. And so I thought I'd talk just quickly about a new drug that has been approved in March of 2025 called gepotidacin, which actually targets the DNA gyrase and topoisomerase 4. And it's been approved for uncomplicated cystitis in females greater than 12 years old. Now, what's interesting about this agent is that it retains activity against resistant gram-negative organisms, including gonococcal disease. So this is a new antibiotic that potentially offers therapeutic options when other antibiotics are not effective against resistant infections. So could potentially be a very exciting novel therapeutic option, and we'll see how it works in the real world. And that brings us to the end of another episode of ID Talk. Thank you again for listening. Remember, AZAAP members can submit questions for future episodes to id@azaap.org. The AZAAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to infectious diseases and immunizations in Arizona, or to become a member, visit azaap.org. And as always, thank you for these interesting consults, and we'll see you next time on ID Talk.